other thing is to pick up on very subtle changes, because babies are not gonna be able to tell us something's not right. We have signs of accidents, we have babies who get hypoxic, we're concerned about SIDS. So it's good to know mom's maternal history, because that's gonna, again, cue you in that this baby who's at risk, but any baby is at risk. GBS is a great example. With GBS, the baby doesn't always give us those classic signs of infection, and sometimes they go home and nobody picked up on the changes in feeding habit, changes in behavior, and that baby gets septic really quickly and dies. So I think we're always watching every baby for risk. Certainly we can look at the labs, but remember, for many of our babies, we don't get any lab data if they're healthy. Now, we talked about cord gases. Blood gases would certainly be a data point for respiratory issues, and then certainly looking at the CBC4 infection would kind of cue me in with that. The other big laboratory data for us is probably going to be glucose and bilirubin. So we would look at those two lab values. So the newborn screen is not really data that we're going to change what we do, because we don't get those results back right away. Those go to the State Board of Health, and it takes 7 to 14 days or so, I think, to get that back. With the baby who is in NICU or that is sick, we need to conserve energy. So we don't want to, again, kind of do a lot of different things with the baby. We kind of cluster our care in sequence, and then we allow time, because that baby is trying to still mature, but it's maturing outside the uterus. And we have to watch how we stimulate the baby. We can actually overstimulate babies in NICU, and they can't respond to all those stressors. Attachment is a huge, huge concern. So we really want to involve the parents as much as we can. If I'm a mother-baby nurse, maybe I want to call NICU and talk to NICU first before mom walks all the way down to the nursery to visit the baby, because I want to make sure that it's an okay time. Some places have rooming in. Some places actually have NICUs designed where mom can stay there with the baby. So it again fosters that attachment. These are kiddos who sometimes have long-term chronic needs. I'll never forget, as a student, I floated at CoSara because I wanted to do peds, at least I thought I did at the time. And so it was really great to go on all the different units. And so I'd often work nights, and I'd be one of the feeders for nights in the NICU. And there were kids who had been there their whole life. They had never left the NICU. And they're 6 months old, 8 months old. It's really, it's amazing. I mean, it's just amazing. But you have to think about that they've never gone home. Being a parent now, I reflect back on that, and it's just really sobering. So NICU care is very complex and a lot of disciplines. So communication is really important. All right, so let's talk about some examples of babies who are sick. So IUGR is intrauterine growth restriction. SGA is small for gestational age. So these are kind of what I call little babies. They're little small babies. And the reasons we might see this could be smoking, drug use, poor nutrition. It's usually something in terms of poor perfusion throughout the pregnancy. Sometimes it has to do with the placenta. In other words, there was not good communication from the cord to the placenta. Maybe the cord insertion was off to the side. Maybe there was a velamentous insertion, but there was something there that the lifeline between mom and baby was not the best. So you can have symmetrical IUGR or asymmetrical IUGR. And what that means is, with the symmetrical, everything is small. So we talk about a percentage. It's below the 5th percentile for like head circumference, height, weight, length, all of that. So if everything is off, that's symmetrical. Asymmetrical might be only one measure is off. So maybe the baby's an appropriate length, but the weight is low. That would be asymmetrical IUGR. So symmetrical IUGR is obviously more serious than asymmetrical IUGR. It's better to be SGA than preterm, and those are not the same. So I would highlight that. That is very important. I tend to be biased. I want to know the gestational age more so than whether the baby's SGA, AGA, or LGA. So on the back of your Ballard scale, you guys plotted your baby's measurements to see what percentile they were in. So that's what the Ballard is often used concurrently with that. But I would be much more concerned about a 34-week AGA baby than a 39-week SGA baby, okay? Preterm is bad, we do not like preterm. They both can be very sick, but prematurity, to me, it is a big deal. So common complications with these babies, very similar to preterm. Hypoxia, aspiration, low temp, low glucose, polycythemia. So with polycythemia, what happens is that you're hypoxic and you increase your production of red blood cells. And so they have an even higher, remember we talked about how the hemoglobin and hematocrit are elevated, in these kids it's even higher. And so with polycythemia, they have this kind of ruddy appearance, they're real red, and that sets them up then for problems with jaundice, because as you make more red blood cells, you have to break them down, and you can't break them down fast enough and get rid of the bilirubin, so it sets you up for jaundice. So the idea behind this is that we're just trying to keep their temp stable, glucose stable, feeding, and again, try and keep them physiologically safe. LGA babies are big babies. They tend to weigh above the 90th percentile. We tend to see this in moms who are having maybe their second, third, or fourth baby. We see it more in male babies. With these babies, I think there was a term on the test that a lot of people got sidetracked with, macrosomia. Macrosomia is a big baby. And usually with macrosomia, macro is large. Macrosomia is a baby who is often normal length, but their weight is elevated. We see this in Hispanic patients and then babies born to diabetic moms. So it doesn't matter what the cause of diabetes, whether it's type 1 diabetes or gestational diabetes, but here's what does matter: how well controlled the diabetes was in the pregnancy. So what would give us data that says how well controlled the diabetes was longitudinally in pregnancy? A1C, absolutely. So if I have a high A1C, am I more likely to have an LGA baby? Yes. Because that means I had too much hyperglycemia in pregnancy. So with these babies, we can see birth trauma, and again, we've talked about all of those things. And again, the thing that sticks out for me when I see a big baby is I'm concerned about hypoglycemia in the baby. So a blood sugar of less than 40, 45. Those big babies, they will often be jittery. It's not a seizure, but they seem to be kind of shaken like a leaf. And again, we tend to see that at birth or delivery because it's a stressor. My sugar drops really fast because you cut me off from my really sweet Kool-Aid lifeline very rapidly. Again, these babies also have polycythemia and hyperbilirubinemia. So I will say in general, you'll notice a theme. You'll see repeats of the same complications. And I think the other thing is, okay, the baby's large. What does that mean long term? It may not mean anything. So for example, you might have a baby who was LGA at birth, but now later in life, they're a little preschooler and they don't continue being LGA the rest of their lives, okay? We really don't get into that until we get into developmental milestones and we kind of plot their growth as they get older. But just because you weigh 10 pounds at the time of delivery doesn't mean you're going to grow up and be 6'7" and 275 pounds or anything like that. Post-term, again, we don't see it that much around here. Technically, again, it is after 42 completed weeks of gestation. In labor and delivery, we are super sloppy because we say post dates a lot. And it's with people often who are in that 41-week window, 42-week window, okay? So with these babies, if you stay inside the uterus after 42 completed weeks, if the placenta's working, the baby keeps growing, okay? Most of the time, the placenta is only designed to work about 40 weeks, but in this case, baby keeps growing, gets bigger and bigger. But what can happen is if the placenta is not working so well, then the baby has to start kind of spinding off their own fat, and they get really long and lean, like asparagus. They're skinny, but their length is really long. They usually have meconium, and they have meconium staining in their skin. They'll have long fingernails, and they have meconium under their nails. It's really icky. Most of the time, the babies I've seen from this situation are folks who were trying to do home birth and did not want to come into the hospital whatsoever. And last resort kind of came in, complications with labor. So again, I think we had some patients from Somalia who, that's probably the most recent experience I've had with a baby that was this significantly post-Aids. Again, those babies have the same complications: polycythemia, hyperbilirubinemia, and again, hypoglycemia. All right, so prematurity. Prematurity affects every single system. Prematurity affects every single system. The more premature you are, the more likely the baby is to die. And so we talked about viability. So in terms of deliveries and delivery team, anybody have a delivery under 30 weeks? Yes? How far, do you remember how many weeks? 27. What did that baby look like?
So tiny.
So tiny.
We actually saw it after the tour.
Yeah. Did the baby cry at delivery at all? No. Yeah. So under 30 weeks, that's and again, we really want to get, because 28 weeks is when we start seeing that production of surfactant. It's not often, it's not like it's all there, but if we can make it to 28, that's really ideal. And again, sometimes those late pretermers, they do okay, they're just really small. They don't always have to go to NICU. So for example, in our units, you might have somebody who's preterm by definition, 35, 36 weeks, but they're stable. So there's no need for them to be in NICU, but we just have to watch their temperature really closely, make sure they're breathing okay, and then make sure that they're eating okay. So here's complications from preterm delivery. They are numerous. So respiratory distress syndrome, you could have a patent ductus arteriosus, anemia. Remember I mentioned delayed cord clamping helps prevent that. DIC, brain hemorrhages, seizures, metabolic acidosis, which can then turn into organ damage. You have huge problems with thermoregulation. Retinopathy of prematurity. Sometimes the things that we do to help babies survive cause long-term complications. So from the oxygen therapy that's administered, it can actually affect the baby's vision. So you may have a baby who's loses their vision due to treatment in the NICU. We also have babies who go deaf from the medications that we use to sustain life and treat infection. A lot of the antibiotics can cause deafness in babies. So they survive, but they have lifelong complications. I mentioned necrotizing enterocolitis, and then speech and auditory deficits as well. So again, we really want to try and minimize preterm birth as much as we can. And preterm is tricky because it's a roller coaster. You have good days and you have bad days. So in looking at birth weight, again, the vast majority of babies who die from premature delivery weigh less than 1,500 grams. So how many grams in a pound? So that's a baby that does not weigh a pound, right? Am I doing my math right? I'm a little foggy-headed, but if you're less than 1,500 grams, you weigh less than a pound. So again, that when you look at this, I want you to, when I think of a baby that small, it's a 22-week or 23-week, it's a really, really small baby. So even if they weighed, they're just so immature in their systems, we can't resuscitate them. Their skin, like sometimes their skin, they stick to themselves, it's so friable, and everything's there, their fingers and everything are there, but there's just not really anything we can do for them. But you can see here, again, when thinking about NICU, so these are babies that we often cannot do any type of resuscitation. With these babies, you can see, again, the marker here is 2,500 grams. So if we can get that baby to 2,500 grams, we're gonna have better luck. Here's preterm, and looking at preterm, we see huge healthcare disparities with African American, Black, non-Hispanic patients. When looking at studies, we've looked at, is it prenatal care access? And we found even with prenatal care access, there's still that disparity exists. So we don't know if there's a genetic component. There's also a theory that about chronic stress and being in a minority So you can see that, again, if I have a patient, who is Hispanic, American Indian, or Black, I'm very concerned about preterm delivery, and those babies, will deliver higher, so. Looking at our report card, so again, looking at a graph, looking at data and interpreting data to help us see how we're doing. It's kind of similar to the breastfeeding. Notice, where do we see a lot of premature delivery? Alabama, Mississippi, and Louisiana. Where do we see good efforts in terms of prematurity? Out west. Okay, so you don't have issues like smoking. You don't have issues like poor nutrition. You don't have access like poor prenatal care, poor oral hygiene. And again, we're doing, not the best here in Kentucky. So, work to be had, work to be had. This is a report that talks about the disparities. And so again, making that difference between white and Black infants who the moms had adequate prenatal care. I think a lot of students, a lot of folks who aren't familiar with healthcare are very judgmental and assume that because somebody is a certain race, ethnicity, socioeconomic status, that they don't get prenatal care. Prenatal care in our community is a little bit tricky because we have these mega offices, and getting into those mega offices, and if you have a bad experience with a healthcare provider, you're reluctant to want to go back. And it's kind of a revolving door. Sometimes you get to develop rapport with the particular provider, but sometimes you're seeing a different person every prenatal visit because they're in the mega office where there's 10 providers. So it's very challenging. In this particular graph, green is good, and notice that Kentucky actually does really well. And so what does that mean? It means that there's not the disparity between white and Black infants who get adequate prenatal care in Kentucky. In my state is horrible. So why is it so bad in Indiana? Indianapolis has one of the worst infant mortality rates in the nation. And again, they don't know why. They don't know if it's environmental, if there's something in the air. Again, if there's some genetic reason, but a lot of it, if you talk with patients, it's how they're treated. They don't seek care from healthcare providers. They're not trusted. A lot of people assume, based off the color of their skin, that they engage in at-risk behaviors. If you think about what's happening in Indiana, in Indianapolis, you have Gary, which is nearby Chicago. So again, there's high-risk populations there. And think about access to NICU. So it was a big deal when Clark Memorial over in Clarksville, Indiana, changed their nursery to a NICU. And the main reason for doing that was because of all the babies who are going through withdrawal. That was the number one reason. It wasn't necessarily to help with premature births. It's more having to do with withdrawal symptoms because of the drugs. I think everybody's heard about Scott County and needle exchange in Scott County, and so. All right, so moving on to sepsis. When we talk about sepsis in a new baby, they're not gonna give us those classic symptoms of infection. So we aren't always gonna see a fever in a baby with sepsis. When I think of temperature with sepsis in a baby, it's temperature instability. So it goes up, it goes down, but you can have a low temperature in a baby, and that's infection or sepsis. Again, the more invasive things we do to babies, we're gonna increase the risk of infection. So any IVs, if you have any breaks in skin integrity, put a tube down baby's throat. And so how do you know your baby's having sepsis? Again, changes in vital signs, changes in neurological presentation. So these are lab tests that we would perform if we're looking for sepsis. So let's say that mom had been ruptured for 27 hours prior to delivery. They're concerned about sepsis in your baby. Your baby maybe doesn't have infection, but is at high risk for infection. Okay, so you're on mother baby, taking care of the baby. Baby seems fine, but the baby still is at risk for infection because of having that exposure, 27 hours of ruptured membranes. So they're gonna do these diagnostic tests. CBC blood culture, C-reactive protein, also known as CRP. It's elevated in the presence of inflammation. It doesn't always mean infection. Another test that you may see that goes with that is erythrocyte sedimentation rate, or SED rate. And again, that is elevated in the presence of inflammation Urine culture and sensitivity. So how do you get a urine specimen on a newborn?
They put like a little bag on there for the males. And
They'll
the females.
do the same for females. So there's a little bag, it has little stickies. They mostly work. And you try, it's like a little Ziploc baggie, but you stick it to their skin and you try to capture as much. So again, culture and sensitivity, sometimes it's not always the best specimen. So in some cases they will catheterize, but again, catheterization not really desired because anytime I put a catheter in, I increase the risk of infection. So it kind of depends on the baby situation and what they need, but a bag is by far more common. You're gonna see the bag on the urine specimen to get the urine specimen for the baby. And then they'll do a chest x-ray and then lumbar puncture. They're actually looking again at the spinal fluid. They should not see any white blood cells in the spinal fluid. If they do, they're concerned that infection has gotten to the nervous system. So in my experience, this has been something that where a baby has suddenly gone into distress and they've taken the baby to a local ER. And it's like not a pediatric hospital or ER, it's some little community hospital. And somebody tries to do a lumbar puncture on like a 1-week-old baby. If I was a parent, I would not want some doc in the box doing lumbar puncture on a baby at all. So they really need to be evaluated by somebody who knows kids, knows babies, that type of procedure. It's just like you want somebody who does it a lot so they do it really well, they do it right, they don't mess it up. But we typically do not see lumbar punctures where we are. All right, so withdrawal. How many folks have had a baby who's been on a withdrawal scale? I would think most of us have. Every hospital is affected, so it's not just a Norton problem, it's not just a Baptist or a U of L problem, it's everywhere. It is everywhere, and it doesn't seem to be getting worse. In some ways it seems to be getting, or it doesn't seem to be getting better, it seems to be getting worse. So how do we know the baby's having withdrawal? A lot of it depends on what particular type of medication the baby's withdrawing from. Here locally, it seems to be heroin, opioids, things of that nature. And so if you think about it, if I rapidly take that medication from you, then I'm going to demonstrate things where I'm in excessive withdrawal, pain, so I'm very irritable, I have tremors, the babies throw up, they have diarrhea, they scratch themselves. They are sick little babies. They're sick little kids. And so we often will use a different type of scale, and we're looking for those symptoms, and are they getting worse or better? In some cases, the symptoms are so severe that they actually will medicate the baby with an opioid to ease the withdrawal symptoms. So it's not that uncommon to have a baby who might be on methadone to ease the withdrawal and kind of, again, gently wean the baby off the drug to get them through that withdrawal process. So in the book, it gives you an example of a scoring sheet. If I'm ever taking care of a baby who's on a neonatal withdrawal protocol, again, you cluster your care, trying to disturb that baby as little as possible. So for example, when I'm with students, if we have a baby that's like that, we don't want to spend a lot of time with our assessment. We're not uncovering them unnecessarily. But those babies, they often will do better if you can kind of bundle them very tightly and hold them very tight. So that, again, if you can kind of keep them snug and kind of more, they do better that way. But these are babies that are sometimes inconsolable, and so sometimes the staff are really irritable because those babies will just cry and have a really shrill cry. And so you might perceive them as being kind of not very caring toward a baby that's going through withdrawal. But I think they're just kind of overwhelmed by the numbers. So just because your baby's going through withdrawal, it does not mean they're going to take your baby away from you either. I think a lot of people think, oh, if the baby tests positive for drugs, they will not send that baby home, and that is not always the case. Sometimes it depends on how much of the drug was there, when the last exposure was, and there's just not a lot of other options for babies to go to. The foster care system here in Kentucky is challenging. And so I think, again, it's a very complex problem. Social work, discharge planning involved, can have child protective services involved as well. So. All right, I think I'm going to stop here because I don't think I could